the Associate Medical Director for Heart Transplant at the University of Pennsylvania. And I am delighted to join you this evening and to talk to you a little bit about post-heart transplant malignancy and why it's important and what we're trying to do about it. Okay?
And with that, I'm going to go around the room, and we'll start with Bob over here to introduce ourselves so you know who your audience is, okay? Bob?
My name is Bob Kelchner. I've had 2 kidney transplants. Sue gave me her kidney in '92. It lasted 16 years, and then our daughter, which is Adriana's mommy, gave me her kidney 8 years ago. And everything's great, feeling good, and enjoying life.
Adriana, you want to introduce yourself?
Yeah.
Go ahead. Who are you?
My name's Adriana, and
Real loud now, real loud.
my name's Adriana, and I just live in here. I don't do anything. I'm just a volunteer.
She's just a volunteer. What did your mother do?
What did your mommy do?
My mom gave Papa her kidney.
Okay.
And Sue?
I'm Sue Kelchner. I'm Bob's wife and Adriana's grandmother. And I was Bob's first kidney donor in '92.
And I'm Pam Gleason, and I'm Jim's wife, but I'm also the mother of a deceased donor.
The mother of the...
A deceased donor.
Steve?
I am Steve Schaefer. I'm a recipient of a kidney in 2013, November 2013, and that took place at Johns Hopkins University.
Okay.
And I'm Harriet Schaefer, his wife.
I'm Paul McDermott, and I was a heart recipient 2 years ago, and Dr. McLean was the one who kept me alive till my new heart showed up. So I'm always indebted to Dr. McLean.
Yes, that's for sure.
My name is Bill Soloway. I'm 9 months post-heart transplant and certainly a patient of Dr. McLean.
Brings her own audience. And,
That's a good thing.
Real fan club.
We just can't stay away from her.
and I told you that Sue Pincus would be here. Susan, why don't you quick introduce yourself?
I'm Susan Pincus. I'm a kidney and pancreas transplant recipient, 10/7/98 at the University of Pennsylvania. So almost 18 years.
Very good.
And you, Mary?
I'm sorry, and I'm Jim Gleason. I'm a heart recipient of 22 years at the Hospital University of Pennsylvania, and it's my honor to bring together our speakers and to both record these for our National Library. So you are the token audience representing people all over the country, and we'll have some Q&A later on. Ask the questions you think they might ask, and yourself. As I always say, what I'm recording is editable. Don't hesitate. If you say something, you say, oh God, I shouldn't have said that. It's okay. You just let me know and I'll edit it out. I've never had anybody ask to edit anything out, but just know you have that flexibility, so don't be shy.
And Jim, thanks for posting this to YouTube, because I do go back to them for reference. So really, it's really handy.
Well, I'll tell you, we've got 80 some odd programs out there so far. Most of them are DVDs, and more recently, because of a snowstorm a couple years ago, we asked the doctor, would you mind if we put it up on YouTube for those who couldn't make it? And she said, fine. And so ever since then, I've asked the speakers, and not a single one has had any reservation about it all. So it's the generosity of our speakers that allows me to make that available to everybody, and it's part of a true service.
Pressure on them.
Wait, this isn't the sex after post-transplant?
No, that's the next one.
You can cut that out, Jim.
No, I'm going to tell you honestly, that was a topic that we do have in one of our programs. And when we put it up at one of our conferences, I was very concerned because we were having a panel. We're going to be talking from a patient view of this stuff. And the nurse who I tried to get to host it was very reluctant. No. I said, listen, you don't have to do anything. We're going to do a survey. We'll use the survey results as the main facts. You just have to host it. And the people, when we got there, said, anybody would like to volunteer for this? We had like 3 or 4 volunteers.
about
got up there.
volunteer. You use that term loosely. They were strong-armed.
I asked,
But they all got into it.
Let's
volunteer, let's volunteer.
all in honesty, they were each asked, and they said yes, and they blew it away. I mean, 2 hours later, when we were through with the scheduled time, basically they said, we should have more time for this. And not only did the nurse who was hosting it, she developed a whole presentation around it, gave that. The panel, I said, you know, be as shy as you want. Boy, they just put it out on the table, didn't they?
Yeah.
And it was a great show. So we have it on a DVD if you want to see it. And it's another topic that I'd love to get, you know, one of our doctors, especially in the heart program, to talk about sometime, because I'd love to put it up on YouTube. Rhonda, with that, I'm going to pass it back to you. You have total control of this. Help yourself.
So, you know, I tend to be rather informal when I give talks, and especially even though I know that millions of people will be watching on YouTube, especially when we're in a smaller group. This is a talk that I give to medical professionals, and so there are loads of big words and all these graphs, but I think that I can make the points quite clear. And if you have any questions whatsoever, feel free to stop me anytime and ask whatever you like, especially if something isn't clear, because occasionally we'll get into our medical speak and you know, and confuse everyone. Let's see. There we go. So there are well-known complications after transplant. And for the most part, since I am a heart transplant specialist, most of these slides have to do with heart transplant, but virtually everything that I'm saying goes for liver transplant, kidney transplant as well. Things are usually a little bit worse for heart transplant than for kidney transplant because the drugs that we use are a little bit more powerful. However, in essence, what I'm saying goes for all of the solid transplants. So everyone worries about rejection, everyone worries about infection, everyone worries about developing kidney disease, high blood pressure, diabetes, and what we're talking about today, cancer or malignancy. All right, so here's one of these graphs that, you know, doctors love to show everyone. So let me, because there are a lot of them, let me orient you just a little bit. So over here, we're talking about free from malignancy. So up here, 100% of the people are free from malignancy. They have no cancer.
Pause just 1 second. Hey, John.
How are you? How are you?
Come on, grab a seat over here in the corner.
Okay, thank you.
And we're going to give you 2 seconds to introduce yourself. Everybody else has already.
Okay, yeah. John Brown, liver transplant 11 years ago.
Okay. Quickie. And that's Dr. Rhondalyn McLean, and she just got started, and we're talking about cancer.
All right. So up here, no one has cancer, okay? And down here, these are the number of years after your transplant. And this is from data from the Society for Heart and Lung Transplant. And it's an international society, so this is throughout the world. So we know that as time goes on after your transplant, you're much more likely to develop some sort of cancer. But obviously not everyone develops a cancer, because you never get down to the 0 here, all right? So some people do and some people do not. What types of cancer do people get? You can see that the vast majority of people who get cancer will get skin cancer, and then lung cancer, and then all these other cancers are a part of the mix as well. So skin cancer is by far the most common
Rhondalyn, you said we could interrupt you, right?
Anytime.
Could you go back 1 slide?
Of course.
I don't see anything about blood cancers. And from what I understood, that's a pretty high incidence also. Is that not on here for a reason, or?
So here I'm talking about, in this particular, I'm talking about solid cancers.
Okay,
Okay?
gotcha.
But yes, it is true.
All right,
And we will talk about those things as well.
thank you.
Okay. So the most common by far is skin cancer, and particularly basal cell and squamous cell cancer. Basal cell cancer is 10 times greater in transplant recipients versus the general population. Squamous cell is 100 times greater than in the general population. Most people develop these cancers on exposed areas like your face, your neck, your arms, places where UV light can get in touch with your skin. Most of the people have lighter complexion. Most people develop between 2 and 3 years after transplant. And we talk about skin cancer all the time, but we rarely talk about lip cancer. And those two go hand in hand. Skin cancers are more aggressive in the transplant recipient than in the general population. 5% of transplant recipients with skin cancers die from the skin cancer, and that's 5 times greater than in the rest of the population. And getting multiple skin cancers, the rate of that is actually quite high. Half of the people get multiple skin cancers. And some people, you remove a skin cancer in one area and it grows back in that same area. Or some people will develop dozens of cancers.
I have a question.
Sure.
Like, would eczema be like a skin cancer?
So eczema is a skin condition, and it can be very dry and you get flaky skin, but it isn't a skin cancer. And most people who have eczema, if you give them medicine and you treat it, it actually tends to get much better, and it never forms any sort of cancer.
Because I had it before.
So I'm happy to tell you that that I don't think you should worry about that. Okay. You can barely see this, but these are all the types of cancer that people get post-transplant. And again, generally speaking, the vast majority of the tumors tend to be solid tumors. And then down here, you'll see things like the blood tumors like leukemia and multiple myeloma. But lung cancer and PTLD are the things that people get. Okay?
Speaking about the PTLD.
Here. Excuse PTLD.
Yes.
What is it?
What is that? It's post-transplant lymphoproliferative disorder, because we like to use big words, okay? And I promise there's a slide that's devoted to PTLD, because it's actually really important here.
You talk about lung cancer being number 2 on the list.
Mm-hmm.
Is that also, if you're a non-smoker, never smoked, are you also still greatly at risk for that?
Yes, you are. And I have a slide on that right now.
Great segue, Paul.
So for lung cancer, so the incidence of lung cancer in heart transplant patients, and it's true of the other cancers as well, is greater than in the general population. And it's not because there are more smokers who get transplanted, okay? Although if you do smoke, it does increase the risk, right? The risk increases with age, it's greater among men than with women, and it's detected really late, okay? We don't find it until, someone has a huge mass in their lung. And because of that, the prognosis is pretty poor. So one of the early interventions that we'll talk about at the last part of the talk is what we're trying to do to make it so that we can detect it earlier and then try to cure it. What is PTLD? All right, so big words. EBV, has anyone heard of EBV? Okay, it's Epstein-Barr virus. Mono, everyone's heard of mono, right? The kissing disease, the teenagers get. So that's caused by EBV. So many of us happen to be affected by EBV, but it doesn't usually bother us, right? It's just a little virus, you know, sometimes you get a little bit of sore throat and then that's it. Not so with people who are immunosuppressed, all right? So PTLD is an EBV-related disease, and it causes the B cells, those are cells that live in the lymph nodes, to start growing and growing and growing, okay? And that is a type of cancer. If you have a heart or a lung transplant, you are much more at risk of getting getting PTLD versus someone who has a liver or a kidney. It's the most common cause of a cancer-related death. It's important to know about. It can cause infectious mononucleosis in transplant patients, but you see that rarely. And it leads to lymphoma. Okay, all of those cells in the lymph nodes start to get bigger and bigger and bigger, and that produces lymphoma. So what are the risk factors for cancer? Okay, age matters. So let's take a look. So this is the age at the time of the cancer diagnosis, and you'll see that most people are around 60 or greater when they're diagnosed with cancer, and these are the different types of cancers that they're diagnosed with. The line in the middle is this is the average age. So, you know, what's this? You know, 67 or something like that for the diagnosis of lung cancer, for example. When you get your transplant, how old you are when you get your transplant also matters. Okay, so as you go down, you know, these people are developing cancer. So if you're greater than age 60, you're much more likely to develop cancer than if you're less than 50 years old when you get a transplant. So as you get older, these are the things that you actually need to be thinking about. And the number of years you've had your transplant also matters. Okay, so this is the number of years from heart transplant, for example, and these are the cancers, and these are the average. So you tend not to worry about cancer in the first couple of years of transplant, but after the first couple of years, you do.
Now, is that because of the drugs we're on?
Hold that thought.
Okay.
Do the numbers drop off after 17 years of transplant, or is it that the data isn't there?
So depending on the type of transplant, so for example, you know, if you have the type of transplant, for example, it's okay. If you have, for example, a lung transplant where the average survival for a lung transplant is 5 years, then you're probably never going to get to 17 years of data. Right?
Well, some of us here, I mean, I'm 17 and a half years out,
Right.
Jim is 20-some years out.
Agreed. And
So
you
are
guys
we
are absolutely
beyond
special.
the danger range, or is it just not data?
There's a lack of data for people who are very, very, very far out because they are very, very special people. Okay. I'm being serious, you know. You guys are definitely blessed. Okay.
I have a question.
Sure.
Is there a way to prevent cancer from happening?
Yeah, it's tough, you know. We haven't figured out the best way to do that yet. I'll talk a little bit about the things that we're trying to do, but, you know, if you grow up and you figure out how to do that, you will be a very rich and lucky young woman.
Famous person.
Very, very famous.
Nobel
She wants
Prize.
to be a scientist.
Oh, so great. Gender matters, okay? Men are much more likely to get cancer than women are. So these are the men and these are the women. And this is, as you go down, it makes you more likely to get cancer.
Do we know why?
No. And if anything, you would think it would be the other way around, actually, but not so. So that was Penn's data, and this data is true all over the world. And this is, it's sort of written a little bit differently, but, these people, as you go up, you have more cancer. So men have more cancer than women do, all over the world. What about race? Does race matter? And it does. So if you take white people here in the red and non-white people up here, white people are much more likely to get cancer than non-white people. I will say, however, that if you take skin cancer out of this, there is no difference. Okay? All right, and then it matters if you've had cancer before. If you had cancer prior to getting a transplant, you're much more likely to get cancer after. It doesn't have to be the same cancer, right? But you're much more likely to get any cancer after. And how long you're cured from a cancer matters. So if you've had cancer in the past, if you've had, for example, prostate cancer 5 years ago, you're going to do better than if you've had prostate cancer 12 months ago, for example, if you then get a transplant. So the take-home points of the risk factors: older age at time of transplant, male, gender, prior smoking we didn't talk about, but it is true. A history of cancer prior to transplant, and immunosuppression may matter, and we will talk about that. So why does cancer matter? Right? Could be you just get cancer and it makes no difference in terms of transplant. Unfortunately, that is not true. And so this is busy slide, but it again is looking at survival. So this isn't developing cancer, this is survival. This is actually living and dying. So the red line up here are people without cancer. They're much more likely to survive than the people on the green line who have had cancer, right?
I'm actually surprised that the difference isn't greater.
Okay, look at this
And the
slide. So, part of the reason that the difference isn't greater is because there is essentially no difference between having a skin cancer and having no cancer at all. Okay? It's the other cancers that make it different. All right? So, for example, this is lymphoma. All right? So this is the PTLD stuff that we were talking about. And you can see here that the survival is much lower. All right, and the type of cancer matters. Busy slide, but skin cancer is just like normal. Having kidney cancer is okay. Lymphoma is somewhere in the middle, and having lung cancer is not such a great thing. The survival is much lower. And these are the other cancers that people get, but they're actually relatively rare. Things like, breast cancer or colon cancer or prostate cancer. And this is for heart transplant. It's a little bit different in terms of colon cancer with liver transplant, but with renal transplant, it looks similar to this. Medications matter. So, forget about what's written on the screen. But we do a couple of things with transplants. When people get a transplant, we're worried that the immune system is going to attack the transplant. So we start them out on a big gun drug that just blasts the immune system, right? Because we don't want the patient to reject the organ. Those drugs, however, are associated with increased risk of cancer, right? So this drug that we rarely use anymore, it's associated with PTLD. This, other drug that we use, also it's used to treat rejection. It increases the risk of skin cancer.
And what would be the common names that we might recognize
You
for those
probably
two?
won't recognize those names.
Okay.
Okay? That's why I didn't tell you them, but you will recognize these names.
How many years after OKT3 does the risk of cancer,
Go up.
I was going to say go down? Like if I had OKT3 14 years ago.
Mhm.
So would I still be concerned that my risk is up, or does the risk go down? I'm so far away from the OKT3.
So I think that the risk is probably greatest somewhere between 5 and 15 years, and then we don't know what happens to you after the 15 years.
Okay.
I told you you're special.
They're gonna study it.
That's a wicked drug.
Wicked drug. Wicked drug. So these are the drugs that you have heard about. Okay, so these are the things like tacrolimus. I'm sure that all of you at some point have been on tacrolimus or cyclosporin, and we know that they are pro-cancer drugs. Okay, they're anti-rejection drugs, but they're pro-cancer drugs.
Does a smaller dosage make a significant difference?
Yes. Okay, most of these things are dose dependent. All right. Other drugs that you may have heard of.
Go back to that last slide, because that last line looked important and popped too quick.
Okay,
There's a
so
higher
I didn't,
incidence,
okay,
lower
so
incidence, okay.
TAC is a great drug. So cyclosporin is, it's the drug that we initially started using for immunosuppression, and TAC came along in the mid-1990s or so. And it's a more potent drug, and it's associated with less malignancy. So it's part of the reason why everybody's on TAC, if you can tolerate it.
Is cyclosporine, is that, I don't know, something called CellCept, is that what that is?
Nope.
No.
Nope, it's a different type of drug. I'm getting there.
So, skin cancer, is it more likely to kill you, or?
No, people with skin cancer, they generally do okay. And part of the reason is because you can see it, you know? It's not one of those things that's inside the body and then people don't know that it's there. They'll see it, you know, on their face. So something looks a little bit different. So they'll be able to go to the doctor right away when they see something. And because that's true, people tend to do okay when they have skin cancer. And we just take off the skin cancer and it may leave a little bit of a scar, but they do tend to do all right. So we don't worry as much about the skin cancers as we do about the other cancers. All right, so Rapa is a drug that some people may be on, especially the kidney people. It helps because it can help treat PTLD, okay? The problem with Rapa is that it's not as strong of an immunosuppressive drug as the other ones, okay? So you can have more rejection with that. Okay, and so when people do get skin cancer, sometimes people actually put them on Rapa, okay? So these were the drugs that we were talking about, the OKT3, the ATG, these are the induction drugs, and this is PTLD. And we see that if you're on these drugs, you're more likely to get PTLD. And you can see that these numbers are years, and they only actually go out to 3.5. So nowhere near that, you're somewhere over here, and we don't know where that is. All right, so yes, malignancy after transplant is a problem. Well, what do we do about it? the keys to what we need to do. We need to be knowledgeable about what cancers we need to look out for, what's our risk, how we can mitigate or lessen that risk. We need to educate ourselves and others about it, and that's a part of why we're here this evening. Screening is the key. We haven't figured out that magic bullet that's going to just pop it in your mouth and the cancer is going to go away. So we need to know that it exists. So screening is a big part of what we do to prevent dying from cancer. And a lot of the research that we do goes into screening. Can we come up with better protocols so that people know when they have cancer so that we can treat them sooner? So there are all these guidelines about how we screen for cancer given a heart transplant, and this is all written on cancer.org. And Penn has something that's a little bit simpler and is more aggressive than what's recommended. So, for example, for breast cancer, mammogram starting at 40. For skin cancer, everybody goes to a dermatologist annually. For cervical cancer, everybody sees an OB/GYN person annually. Colonoscopy for regular people, it's 7 to 10 years. For transplant people, it's 1 to 5 years based on what we found on your initial colonoscopy. Annually, men get a prostate exam and a PSA drawn. And then for lung cancer, which is one of the ones it's really important, we have actually changed what we do. Before we just did chest x-rays every year. And now we are actually doing chest CAT scans on people who we think are high risk. And those high-risk people are the people over the age of 60, if you've had a heavy smoking history or if you've had a history of lung cancer. All of those people get screened that way. Screening is the basis of our figuring out how to deal with cancers.
Just one comment on it, if I may. I think it's very important what you're saying in terms of when a transplant doctor looks at you. This is what they're recommending. You go to your local family doctor or go to a specialist in some other area, they're saying, oh, you don't need that. And you got to speak for yourself and say, no, wait, you don't understand. I'm a transplant recipient. We're at higher risk for this. And so what do I have to do more than that?
Agreed.
And like the PSA, the advice I got originally, this was 6 years out from transplant. There was some higher PSA. Oh, it's slow growing. You're not going to have to worry about it. I said, no, you don't seem to understand. And I found out the gold standard was biopsy. And not comfortable, but it's done. And after a couple of those, they did find it. And it was radiated. And I'm now 10 years out, or what are we now? 15 years out from that. And it hasn't been a concern. But again, that was a very highly regarded urologist who said, you don't need that. So be very careful that you're talking to somebody who knows transplant, is my point.
Right, I agree, absolutely agree with you. So when things go wrong, when something's not quite right, the doc in the box on the corner, care first or going into the CVS, doc of the day kind of thing, probably not the right thing to do, okay?
Now, would your insurance company make you still have the chest x-ray first before you would be permitted to have the
CAT scan,
The CAT
we would
scan.
probably have to call, but it would get done.
Okay.
Do you require patients to come back on a yearly basis for physicals like that?
So we see our transplant patients when they're far out every 6 months. Not everybody does that, and not
Every 6 months?
We see, so the nurses, on the annual visits, a physician sees the person.
Oh, okay.
Okay, and then the 6-month visit, a nurse practitioner will see the patient. But we
Again-
make sure that everything is done that we have a checklist of everything that needs to be done because we know that these things exist, but your best advocate is you, right? It's best for you to know.
The area where I've seen the most concern in our post-transplant cancer website plays into this, right? Kidneys, many programs are so big that they refer their kidney patients back to a local urologist who is not transplant related and so falls in that category I was just talking about before. Now the heart programs, man, they own us for life,
It's true.
okay?
It's true.
And we love it because, left to our own devices, the guy is not going to get a prostate exam. But that's part of the protocol, baby. You get it done, and the first time you know you're having concern is when they say, by the way, your PSA is raised. I'm sorry, what's a PSA, So, very critical.
Certain hospitals require, I know the one
Right,
I go back each year and
yep.
do a 6-month follow-up with local doctors.
Right, but you're absolutely right. The kidney at Penn, you also go back to your own kidney doctor. And so, this is, is really important for you to know. And people, sometimes doctors get upset when their patients look on the internet to find things, I certainly don't get upset. Most of us don't get upset about that. Knowledge is power, and if you read something on the internet, not some blog somewhere, right? But if you read something, on the internet and it's something that concerns you, then you should bring it to your physician and ask about it. No one will, certainly no one at Penn will ever, fault you for wanting to be responsible for your care.
Go ahead.
I know you mentioned the lung cancer being one that's hard to catch, and it's usually a big mass when you do catch it. But I also know Penn takes the protocols real seriously. So Penn's of the opinion that if we do that chest x-ray once a year for the typical patient, they should catch it before it's a big mass.
That's enough for the typical patient, okay? Because there's risk to doing CAT scans on people. And we use low doses of radiation for the protocols that we're talking about now, but not everything that we do has a risk to it. So the screening that's done should be individualized. One size does not fit all, and that's essentially what that slide says. I'm actually gonna go to what we've chosen to do in terms of research. It's okay to set up protocols, right? But if the protocols don't work, then they don't work. If we miss people, or if we catch too many people, or if we spend too much money of the hospital's money, and they say, what are you doing? So whenever we change a protocol, we actually do research. And this is the screening research that we're doing now. So EBV is associated with the PTLD, lymphoma thing. And so what we're trying to do is we're trying to take those people who test EBV positive and actually use CT scans to screen them for any enlarged lymph nodes. So that's part of the research that we're doing. Again, there are issues with, screening people because with excess radiation, you can actually cause cancer, right? So we want to make sure that we screen the right people. We don't want to screen everybody because we're not going to, most people don't get cancer, and it would be a waste of resources and a lot of radiation to the individual. So what we do is we check an EBV test on everybody to establish a baseline. So if you're EBV negative, right, and then you become, if you're EBV negative and you receive an organ from someone who's EBV positive, you're at really high risk. And it's those patients that we want to that we're going to go screen. Subrezina is she is an amazing heart failure transplant cardiologist that works out at Radnor. You know, I think you get the people who are associated with Penn know Marielle Jessup and know that name, right? And Sue Brazina's name goes alongside of hers. She just happens to be out at Radnor. And she has a ton of transplant patients, heart transplant patients. And what she realized was that there is a marked increase in kidney cancer in her patients. And so she set about different screening protocols that we will use as research. So she'll take her patients and she'll either, one, do exactly the same as we do right now, which is nothing but do a urinalysis, or two, I'm sorry, you do nothing, because we don't actually, at Radnor anyway, we don't actually do a urinalysis. Or two, we get a urinalysis, and if positive, we do more testing. Or three, we can actually do an ultrasound at 5 years and beyond. And she wants to see if we take our patients and we divide them into the 3 groups, if we're going to pick up more kidney cancers based on which group they're in. Okay? Screening is what we also use for research. Someone asked a question about whether or not the drugs that we use actually cause the cancer. And it is true, as I pointed out, that drugs like cyclosporin, tacrolimus, are actually associated with things like PTLD. So what happens if you just decrease the amount of medications you're on? So it's not uncommon that someone will have 1 or 2 skin cancers and will end up decreasing the MMF, the cell set. Okay? So we do that all the time. So people come in on 750 milligrams of cell set twice a day. They'll start having loads of cancers and we'll decrease it to 500 milligrams. Right? We do that. And the question is, sorry.
The rituximab. That's something that was tried with my husband,
Okay.
and it didn't work at all.
It was trying to reverse
Yeah.
a nephrotic syndrome.
Uh-huh.
Yeah, and it was.
And it failed. It was a doctor, as a matter of fact, hematologist from Penn. But it had some pretty tough effects.
It does. It
Yeah.
does. So, you know, all of these drugs, they're designed to obliterate your immune system. And that means that bad things can happen when your immune system isn't in place. And so so they have terrible side effect profiles, okay? And any time that we use them, we could potentially run into trouble. But it's also true that any time we decrease them, we can run into trouble too, because you're no longer protecting yourself as much. And so then you are at risk for rejection. So if you reduce the immunosuppression until the RI is there, then you can increase your risk of rejection. So it's all a balancing act and a trade-off. Okay?
And is that risk of rejection reduced long-term out?
No, as a matter of fact.
I mean, at a certain point, I'm sure.
So it is true, I understand what you're asking.
Yeah.
So it is true that, that the longer you go out, the less likely you're going to reject, okay? Liver people almost never reject, okay? It's actually a very interesting phenomenon, you know, and for example, you know, people get very happy if you have both a heart and a liver, because the likelihood that you're going to reject if you have a heart and a liver is much lower than if you just have a heart.
Really?
Yeah, it's true. So it's actually pretty relatively protective. So as you go out from transplant, your risk of rejection goes low. Your risk is highest in the first 2 years, okay? And then it goes low, 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 low. But if you change the immunosuppression, it changes the ballgame. okay? So sometimes people will come in these rip-roaring infections, and we reduce the immunosuppression and they have a rejection. Or sometimes we'll reduce the immunosuppression because they've got terrible skin cancers and they'll have a rejection. And it doesn't matter how many years you're out, you're at increased risk. It's not automatically going to happen, but you're at increased risk of it happening.
And just out of curiosity, what understanding is there behind if you had liver and heart, why would the rejection?
I wish I could bottle
Okay.
that one too.
Yeah.
Because if I could bottle that one.
It's observable, we don't know why. Got it.
We don't know why. All right, so this is probably one of the last graphs that I'm going to show you. So RI is reducing immunosuppression, so it can be very effective in PTLD. So this is surgery followed by reducing the immunosuppression for PTLD, okay? And you see this is the survival rate here. This is reducing the immunosuppression alone, and this is doing neither. Okay, so whenever someone has PTLD, we do reduce the immunosuppression. And if they reject, we'll deal with it. So the algorithm, what we need to do, in order to prevent and post-transplant malignancies, risk factor modification, stop drinking, stop smoking. You need, for viral infections, you need to be tested to make sure that you don't have CMV or a lot of EBV is always positive. Once it's positive, it's always positive, but they can count the number of copies of the number of viruses in your blood. So you want to use antiviral prophylaxis within the first 3 months of transplant, and we do it actually for 3 months for everybody. Cancer surveillance is probably the most important thing. Derm, having a colonoscopy, having your GYN exams, men having a prostate exam, and breast cancer in females. So one of the things I didn't say that's very important to note is that it is true that prostate cancer grows slowly in your average man. Okay, prostate cancer grows much more quickly in someone who has immunosuppression on board. All right, so cancers grow more quickly in people whose immune systems are suppressed.
What is up in risk factor modification? Avoid voriconazole.
So voriconazole is it's a medicine. It's an antifungal medicine, and so there'd be no reason for you to take it unless you had some sort of weird fungal infection. So that's just doctor speak stuff. People don't usually get voriconazole. If you do get it, it's...
Is it strictly treatment for a fungal infection?
Yes.
If you were going on a trip to third world country,
You wouldn't get one.
you wouldn't get it prophylactically?
Nope. You wouldn't get that. Statins are, Lipitor, things like that, are associated with a decreased risk of cancer. That's why everybody, all the heart transplant patients are on a statin.
Lipitor is associated with decreased risk of cancer?
Absolutely.
I thought it was, that's good news, I thought it was just there because they knew I had a chance of getting plaque and everything.
Nope, that's not why you're taking it.
Oh.
And that's all statins.
I'm
Yep.
kidney pancreas at Penn, and I'm not on it. And I don't have high cholesterol, which is another reason they put on it, but
Right, so that
it's
is,
not in the kidney program?
so, I'm actually not sure about, I know that it's true for hearts.
Okay.
I'm not sure whether or not it's true for kidneys, but I can look that up and I can easily get back to you.
All right, I can ask my doctor.
I seem to recall, and I'm not sure if it was statins or not because it's way back there now, that they sort of discovered that if you go back 20 years ago, a lot of the loss of the hearts was because of hardening of the arteries. And by using statins, they seem to avoid that. They didn't know why, but by using statins, they didn't see that happening. And so along with, we think in terms of cholesterol and so forth, but in hearts, they found that was a preventative for a very common concern. Do I have the right drug?
So yes, so it definitely helps to prevent atherosclerosis, and everybody develops atherosclerosis with age, and again, with immunosuppression, it tends to go faster than with people who are not on immunosuppression. But even irrespective of the disease of the arteries of the heart, it is associated with a decreased risk of cancer. Okay. All right, and then the making sure you're vaccinated and that you get your acyclovir or ganciclovir, whatever you're using to prevent herpes-related viruses while you're on such high suppressive therapy. And I think the highlights: cancer is highly prevalent in post-transplant populations. Skin, lung, PTLD, the most common cancers. Risk factors include age of transplant, how long you've had the transplant, what your sex is, and having a prior cancer. Medications and treatment for rejection can have an impact on malignancy. Having a post-transplant malignancy can lead to poor outcomes. Post-transplant malignancies tend to be diagnosed late, so screening is the most important tool for diagnosis. Knowledge, education, screening equals power. All right, that's all I got for you.
That's a lot.
That's very good.
Well, one of your earliest slides, Dr. McLean, you showed that the skin cancer usually showed up in the first 2 or 3 years.
Mm-hmm.
But then that next slide showed still the increase of cancer. That
It shows up.
like in 20 years, it shows up in 50% of patients.
It's true.
So even though it doesn't show up in the first 2 or 3 years, you're probably still going to get it, or
You're probably
have a
still
1 or
gonna
2
get it.
chance.
You're probably by year, wherever
The
you
longer
are,
you live,
the longer you live, the more likely you are to get skin cancer.
And part 2 of my question is, on blogs, I guess, but hopefully some decent blogs, they've talked about still the benefit of the sun for about 20 to 30 minutes a day. When I'm using all the sunscreen and the hats and all covered up, which I'm doing, am I not getting the benefit of the sun anymore?
So I think they're talking about just making sure you have enough vitamin D.
Vitamin D,
in
yes.
your system.
Yes.
And yeah, there's some benefit to that, but it takes, but you want to spend a ton of time in the sun because you're just going to be at increased risk. And yes, it's true, and you can supplement your vitamin D in other ways.
Okay.
Now, Paul, how long are you out from your heart transplant?
2 years.
2 years. Bill?
9 months.
Okay. I want to say something, and she can comment, correct this any way you want, because I don't want those of you just fairly recent to be overly concerned with rejection. Certainly it's serious, but from one of the other programs in town, we had a speaker, and it was focused just on the hearts. And he said, over the years, he's been around a long time here in Philadelphia, we've been so over-medicating our patients. And today, and this was probably about 4 or 5 years ago, okay? He says, today when we see rejection, we watch it. We don't do anything for it, unless it's real significant. But he says the body seems to be able to take pretty good care of it. So we'll monitor it closely, but we don't react to it like we used to. Now again, every story is different, every individual patient is different. But Rhonda, would you care to comment on that? Is that something that would be generally viewed as being true, or just is that his opinion?
That's his opinion.
Okay.
It's not true.
Okay.
It's not true.
And that's how he treats his patients.
There are grades of rejection, right? So there's just, you get biopsied, you take a look at the biopsy, and you have a mild rejection. So you either have no rejection, you have, sort of something that we don't really worry very much about, and then you have a direct rejection that we see with the microscope. Or you can have a rejection that we see with the microscope and you get an echo and the heart function isn't normal anymore, so that's a different ballgame. Or you end up in the hospital because you're sicker than anything else. So those are 3 grades. They are all treated. Okay, they're all treated. The risk of not treating them is you would go through the stages of getting worse and worse. And so we treat rejection. We give different drugs based on what stage you're on. So for the first stage, we could just give you some 3 days of oral steroids. You know, for the second, you know, we would give you steroids plus the drug that you had, you know, Ritux or something like that. And for the third stage, those people are really, really sick. Generally speaking, rejection doesn't scare us that much because we're almost always able to get people out of rejection. Okay. It comes with a price though, because it's a lot of immunosuppression, extra immunosuppression that we use in order to get you out. But we are able to get most people out of rejection.
I would add to that, if you run into people, and so for example, I was sharing, running into a fellow who's out 34 years from his heart transplant down at a conference in Baltimore, okay? When you run into somebody that far out, that's a different world. They were treated so differently than you are, and even that I am. So when you see a survivor out that long, you say, wow. You see somebody out 20 years, wow, that's pretty good, you know? And I'm truly blessed. I'm not taking anything away, but I'm telling you, you get out 25, 35 years, you are in a different world. And that's the progress that's been made by the teams with this kind of research and this kind of education that people are getting, and the screening. Now, the other thing, I've been very focused on post-transplant cancer because that's what TRIO is doing, providing this education. And so anytime I run into somebody who has been diagnosed with a cancer post-transplant, I'm always curious, what organ do they have and how did they find that? Because forget skin. I mean, we understand that. It's so common, everybody knows all about that. But you get into some of these other ones that don't have any external symptoms. How did they spot that? How did they spot my kidney cancer? I had no symptoms. It was some proactive doctor recommendation for something else, and while they're there, they happen to see it. And so there's a word for that, coincidental maybe, I don't know. But
Incidental.
Yeah.
An incidental finding.
An incidental finding. In other words, they're looking for something else and they say, oh, by the way, that kind of stuff. So the message that we also give in our education is listen to that doctor, you know, and you say, I don't need that one. You know what? It's God sending you that rowboat and you say, no, you know, I sent you this, this, and this, and you didn't take it, right? And the doctor tells you to do something. So I was very fortunate with Dr. Vaughn, who helped me when I faced that prostate cancer back in 2000. And what was interesting about that is, at that point, I was very much thinking to myself, okay, I'm out 6 years, average life expectancy after transplant was 9 years. How aggressive do I need to be about the prostate? And I couldn't ask the heart program because they really didn't want to address this. What is my life expectancy? What, you know, how long do I have before I die? I mean, it's not a question you get an answer to.
Let me get my crystal ball out.
But Dr. Vaughn was the third person I talked about the prostate cancer, and he was a generalist. So he wasn't pushing surgery, he wasn't putting radiation, he was looking at the big picture. And he said, let me do some study on that and I'll come back to you. And he did. And he said, after his research, at the stage you're at, it's no longer a factor. You need to treat the prostate cancer. Prostate cancer, your longevity for the heart side is not a factor anymore. Mm-hmm. And so once you get past that first couple of years, it's always going to be with you. But the weight it carries is a little bit different when you're facing some of these. Mm-hmm. And again, she's going to correct me if I'm misstating that because...
I believe everything that you just said. It's correct.
It makes it very possible to live a very fulfilled life without being overly protective.
Right.
And
I will say that, you know, I presented all these really horrible data, right? But most people don't get cancer.
Yeah, that's what I was going
Most people do not get cancer.
Right.
You just have to know that it exists and know that you need to be screened. Okay? This isn't meant to scare you or anything like that. It's all about you know, one day I may face this, I really hope not, but this may be the case for me. I want to make sure that I have good people taking care of me, and I want to make sure that I'm taking good care of myself. That's what this is about. Not, oh my goodness, look at me, I get cancer. Because I really don't want that to be the message here this evening. 'Cause it's
I think
not
your
the one
keys
that I
brought that out. Education, prevention, et cetera, it's all in perspective.
Doctor, I want to frame the question a bit differently. Because you did show some statistics that weren't cheerful statistics, but they're based on today. And the one thing I'm always impressed about HUP is the collaboration they do between the research, the pharmaceuticals, and the doctors, the clinics. Those statistics won't be the statistics I'm going to see in 3 years when you project it 15 years in, and then 5 years from now when you project it 15 years. But the key question I have is, the drugs I'm on today, are they going to cause something permanent to me, or as you find new drugs that have less negative side effects, will I be in?
Right, so
Better
all
condition.
we used to have was cyclosporin.
That's a great
Right?
example, yes.
You know, and now we've got TAC, and TAC is a much better drug.
If I had known the other though, would it have caused permanent harm, or would I have been passed it and on to TAC?
I don't know,
Oh,
right? So, you know, TAC is less harmful in terms of malignancy
Yes.
than cyclosporin. Will we develop more better drugs? Yes. If you looked at, I think you were saying when someone asked you the question about, you know, what's the average lifespan of someone who has had a heart transplant, you know, it gets longer and longer because we get better and better. And so, yes, you know, by the time you're 97, you know, you'll be on drug XY492, and things will be going great.
Rhondalyn, we have always a parting gift for our speakers. Susan is presenting to you something that hopefully will add some inspiration each day to your very hard work over there. And we thank you very much for your time, and certainly this is so perfectly aligned to what we need for our post-transplant website. And she and I sat down and talked about this beforehand, so you've really tailored this to what we were hoping to hear. And again, put it in perspective too. You know, knowing the risk, you look for it, you take care of it, as opposed to being afraid of it. I mean, the big C that we grew up in, we heard, is no longer the big C.
Agreed.
It's something that has very high cure rates these days because of all the medical advances and for the early detection.
Yep.
Can't thank you enough.